Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello to you. Thank you so much for joining us. I am Mike Buck. I'm an old guy. I'm also a patient, as well as the show's facilitator. And I know a lot of you guys, when the show comes out, say, I got to go. I'll go out in the garage. You listen to your vein show. And I'm a patient. I'm a male. And today, break the mold. We're going to talk about a case study. And I love it when we do case studies because everybody out there falls somewhere on this bell curve of venous conditions, whether it's a little spider vein or a big old leg ulcer or somewhere in between. And it's usually hereditary. Contributes to it. And it's not usually women, middle-aged women, that for vanity's sake want their legs cleaned up. As a matter of fact, ladies, you get to go out in the garden if you want. No, I'm kidding. We want you to stay right where you are. Today we're going to talk about a deep vein thrombosis, a deep VT. It's a case study, and this is a male. And it's right up the age pipe, right up the demographic that we can talk about, 66, or as they say in Great Britain, clickety-click. Isn't that kind of funny that a lot of people, and I don't want to say pleasantly surprised, but the first time I came to the clinic, I saw equal opportunity chairs, men and women. So this is, it's usually, am I right? It's usually thought of because of the cosmetic thing. It's a bathing suit ladies deal.
Yeah, definitely. And, it's one of the hurdles we have to try to get over all the time. And that is that, you're right. I mean, I think the typical thought of people in general, if it's a vein problem, it's got to be a middle-aged woman, and it's mainly cosmetic, and and that's the that's the demographic that gets conjured up. But we see many males in our practice.
Okay, so we dropped the lasso around this guy today, for a reason, and I'm not saying because that's the average, but isn't it sort of typical that if you do have serious problems, that's around the age where they become they threaten your quality of life.
Age is a risk factor. Mm-hmm. So, and I think age just means that you've had your vein problems for a longer period of time than other people. But like you said before, it's it kind of comes down slowly. And it starts out in a minor sort of fashion, but once you get to the age, roughly the age of the gentleman we're going to talk about today, mid-60s, you're starting to have real significant problems, and they become symptomatic, and sometimes they can become actually life-threatening, quite frankly, as we're going to see today. Okay,
and as you know, gang, I love it when we do this because Doc just to get to tell you all of this stuff. Where I come in, and that is, I think, where I want to lend credence so that you all get this. It will be a valuable experience for you. We talk about this in broad strokes of the brush. Here is an actual guy. And the thing that always gets me going, and my first and maybe only question during a great part of this presentation is, what was the trigger? What brought him in the door?
Yeah. Well, what brought him in the door was pain. Mm-hmm. And, we're going to be talking about this gentleman because he had, as it turns out, he had a DVT. What we call deep venous thrombosis. And I wanted to talk about him specifically today because March is always DVT awareness.
Month,
and it's always a good thing to remind people of, a vein issue that can be much more serious than most of the routine things that we see day to day. And again, like I said before, can be fatal at times. But this guy, he's 66 years old. And relatively healthy. He's a smoker, so that's not good. He's been smoking many years. Yeah. And he's a little bit on the obese side. He's 5'8", and he's 240 pounds. So he's got what we call a body mass index or BMI of 36.5. That's well above normal and definitely into the obese range. So he would be considered obese. And he leads a fairly sedentary kind of lifestyle, so that's never good. But he's working. He works in the computer industry, typically behind a desk, and he travels occasionally. So the only medical problems he had were high blood pressure and high cholesterol. He was on medication
on meds for that.
And those two things were controlled. He's never had heart disease, never had a heart attack, never had major kidney problems. Didn't have, I don't recall any major, surgical kind of procedures that he had. So, other than the fact that he was a smoker, he was overweight. He's 66, high blood pressure, high cholesterol, but that's pretty average, and unfortunately that's kind of average health for the United States at this moment.
I got to drop in on one thing, and that is when you talk about blood pressure, I have this friend that says, oh, yeah, I used to have high blood pressure, but I'm okay now.
Yeah.
He's okay because he's taking meds.
Yeah.
So what happens is you're only okay to the med to that point.
Right.
But, isn't it like glasses? Sooner or later you need stronger ones.
Yeah.
And I'm saying that sooner or later you don't need one blood pressure pill, you need two.
Yeah.
And then you need four. And then you do have a blood pressure problem.
Yeah. Well, and it's funny you say that because I hear that all the time.
I'm sure.
Because one of our routine questions is, do you have high blood pressure? And you'd be surprised at the number of people who say no because I'm on blood pressure medication and it's okay.
And one more thing, gang, because as you know, I'm a patient. And one of the things that, having different surgeries and different things, knowing about these things, when Doc asked me through this question period that he goes through, you answer a lot of questions about diabetes. And I said no, because I did have type 2 diabetes. And it did go away, and it did not come back. And I'm taking no meds.
Yeah.
But a lot of people get lulled into a false sense of security. Oh, yeah, well, I used to have diabetes, but I'm okay now. But I take these 3 pills every day.
Right.
Yeah. I still need sugar, though.
And you're right. You do get lulled into a false sense of security because, the medication seems to work. And blood pressure is another one of those things. And you're right. As you age, your requirements for antihypertensives or blood pressure medication, they may change. You may require more, and it's something that you have to keep track of. Because as time goes on, if you are on the same medication and your blood pressure is not being controlled, then that's as bad as having uncontrolled high blood pressure, which can be dangerous. They don't call it the silent killer for nothing.
Yeah. That's why I love getting into this guy, because he's right up the pipe. I know a lot of you are listening, and by the way, you can do more than listen. Whenever you have a question or a comment or you want to learn more about venous disease, you go to veinclinicsofhawaii.com. Veinclinicsofhawaii.com on 4 islands, a myriad of information. And if you want to hear something on this program, there's a contact us, a click right on that. Go ahead and say, could you please tackle this on one of the radio shows? And we most certainly will. We do a question, a mailbag every now and again. We've done a couple of them. We've got another one coming up pretty soon.
Yeah, you're right. It's on our homepage. You're going to see a picture of you and I.
Yeah, you can even listen to the shows.
And you can listen to the shows. But
you can have a binge listening to the Vein Clinic show.
Yeah, just like Netflix. That'd be neat. So anyway, this guy came into the office, and his main complaints were calf pain and swelling. And he said it had started about a week prior to him coming in. We always ask, especially with people who we suspect might have DVT or deep venous thrombosis, what was going on around the time that your symptoms started. And he had a history of travel. He had family in North Carolina, and he had been there visiting them for some period of time. He was a little more active probably while he was there. They were, running around doing touristy kind of stuff. And then so he was a little tired from that, but was feeling well. Then he got on the plane to come back home, and during the plane ride, that's when he developed this achiness of the right calf.
That's not uncommon, is it?
Yeah,
that's sometimes where it manifests.
Well,
Yeah.
definitely,
Yeah.
definitely. But I think he was he sort of didn't make too much out of it because he had been a little more active the week before while he was visiting family. And he sort of chalked it up to that. After he landed, however, the pain, and he got out of the plane. He was walking around, obviously going home, and it got a little better. So again, he was probably lulled into a sense or a false sense of security. But after a couple days, pain came back and started developing a little more swelling. And on the 6th day, he woke up and really had very substantial kind of pain. And the calf was tight, a little tender, and it was at that point then that I think his wife had heard about us or knew about us in one way or another, and she talked him into coming in to get evaluated. So when he came in, he was moderately obese. We examined his legs, obviously, and he had varicose veins in both calves, and he had stated that he had those for many years, and had never had any treatment for those. But said that he was having, kind of minor to moderate symptoms that he felt probably were due to the varicose veins, but didn't neglected to have them evaluated. Didn't feel compelled to do that. With closer questioning about his vein history, then, as it turns out, he had a couple of episodes of what we call SVT, superficial venous thrombosis. So, what is SVT? Well, SVT is something that we kind of refer to, and lay people in general refer to as phlebitis. They've got an episode of phlebitis. Well, what is phlebitis, or what is SVT? SVT is typically an area of varicose veins that, for whatever reason, may suddenly thrombose, clot off. And sometimes it's from exertion, sometimes it's from trauma, sometimes it just happens. But when those varicose veins become thrombotic, or they clot off, then it creates inflammation in that vein and around the vein, and it can be quite tender. And the typical signs of superficial phlebitis are redness, tenderness, warmth. Sometimes people think it's an infection. It's not really. It's just a thrombosed vein that has become very, very inflamed. So we asked him about that, and as it turns out, he had a couple of episodes, a couple of different episodes in the past. So that's a little bit of a red flag.
Did he just put up with him?
Yeah, he did whatever. Yeah, he just kind of, I guess, worked through it, powered through it. Didn't really seek, medical therapy for it. And typically that'll happen. I mean, if somebody develops a little area of phlebitis, the usual way that we treat it is to treat with anti-inflammatories, like ibuprofen, Advil, Motrin, Aleve, these types of things, and warm, moist compresses can sometimes kind of help symptomatically. Get them into compression stockings. Usually always they are associated with varicose veins. So we encourage evaluation.
One thing that I think is magic about that, and trust me, gang, I'm a believer. I don't say this. I wear them every single day. But it's counterintuitive unless you're Dr. Juleff to say, wait a minute, I have a swollen leg, so I'm going to put these things on which are really tight.
Yeah.
Isn't that going to make me more swollen? Well, no.
Right. No.
What happens? Why is this compression so valuable?
Well, the compression is valuable because of the way the stocking is constructed, and we've talked about that before. How it's not a piece of clothing.
Yeah, right.
They really are constructed in a very specific sort of fashion, and we call them they're called medical grade graduated compression. So what that means is that the most compression is down there around your toes and foot. And then as it comes up the leg, the amount of compression that your leg is feeling from the stocking lessens.
Okay.
So, and that's why typically when we talk about stockings and we talk about the amount of compression that pair of stockings might have, we refer to a range. So typically, we in our day-to-day practice use either 20 to 30 or 30 to 40. And that's millimeters of mercury. So that, and that's just a pressure unit.
I call it doc talk. You don't have to pay. Listeners, you don't have to pay attention on that part. That's just doc talk.
Yeah. It's the same. When you get your blood pressure taken, your blood pressure is in millimeters of mercury. So same kind of thing there. But so the pressure lessens as it comes up your leg. Okay. So the theory there is that the whatever excess fluid you have in your leg, that's going to be sort of moved
brought back up,
moved in the proximal, in the upright or the upward direction. And they work. They also create a little bit of compression on your veins, and that helps your veins to function normally.
That's my benefit. That's what I'm getting at.
Yeah, and then in a case of somebody with phlebitis, we want to allow for compression of those varicose veins so that the clot that might be in a superficial varicose vein is not going to spread. It's not going to propagate through more vein if the vein is compressed. It can't do that. So
love my stockings.
Anyway,
okay.
Yeah. So he had a couple of episodes of these, and again, that's sort of a red flag for us because when people have multiple episodes of venous thrombosis of one sort or another, then we wonder if there's something more going on than just, sporadic things.
In other words, can you say the difference is maybe one would be an event and the other would be a condition?
Exactly.
So that an event is, if it happens again, now pretty soon you have a problem.
Yeah. No, you're right. Yeah. You're absolutely right. And that's basically what is going on with this guy. We'll talk about it a little later. So then we asked him about his family history, and as it turned out, his mother also had a DVT right around the same age, mid-60s.
Thanks, Mom.
Exactly, yeah. I mean, her DVT probably occurred for the same reasons that his did. And she was put on blood thinners, and he wasn't sure of the details, but she was, kind of treated routinely for DVT with blood thinners, but never really was evaluated further other than that. So we did, we did our usual workup after we, talked to him completely about his past medical history and past surgical history. And we did a diagnostic ultrasound, which is what we do in many people, not only looking for DVT, but also just in general when we are evaluating vein function. For people with routine venous insufficiency, ultrasound is the primary thing that we do to diagnose that these days. And he did have venous insufficiency in the saphenous system. So he had, in both legs, his superficial venous system was not functioning, and that's due to a failure of the one-way valve function, and the blood rather than going up is going down. And he was probably having symptoms from his venous insufficiency prior to all this. He was just kind of ignoring them.
I was going to say, in that they probably come on pretty slowly, don't you? Just sort of get used to them,
right? Yeah. In so many cases, people will come in and say, "Well, I don't seem to be bothered by my varicose veins, but the symptoms come on so slowly and over such a long period of time that they're chalking it up to other reasons." But people say, "Well, I'm just getting old, and that's why my legs hurt." Or that's why I get tired, but sometimes that's not the case, and sometimes we can make that feel better. But so in addition to the venous insufficiency and the bilateral varicose veins that we mentioned, he also had a deep venous thrombosis, in the calf of the right leg that started in the calf but extended up behind in the main vein behind the knee and then into the mid to upper thigh. So he had a fairly extensive DVT,
By the way, gang, when we talk in previous programs, you know that this clotting we're talking about and this DVT is a lot bigger than you thought. It's not a little thing like when you get a scab or a clot on your finger. This thing can be sometimes very lengthy.
Yeah.
You just talked about a good part of that body that it traveled up on him.
Yeah. So if we're talking about, and this is a pretty typical kind of scenario for people who develop DVT, especially in this situation where, starts in the calf, comes up below or behind the knee, and then all the way up into the upper thigh near the groin. So that's a pretty lengthy clot, and the diameter of that clot especially in the upper thigh could be the size of your little finger.
Wow.
So it's
like a piece of rope.
It is. Yeah. So we started him on blood thinner. We did the usual things. We started him on blood thinners, put him into compression stockings, and since he was not having a tremendous amount of symptoms, he was having swelling and pain, but it was tolerable, and there was no question that we could treat the patient as an outpatient. We didn't have to put him in the hospital. Now in the old days, before we had the newer oral anticoagulants that we have now, often we had to put this kind of patient in the hospital and start an IV and give them intravenous anticoagulation for a little while until the oral medication, which primarily was Coumadin. I mean, I think most people have heard of Coumadin or the generics warfarin, and the problem with Coumadin that we don't have with these newer anticoagulants is that it always took several days for the Coumadin to kind of kick in.
Yeah, you said
and
that.
So, during that time, the patient had to be on some immediate form of anticoagulation, and that was the IV heparin, as it turns out, was the medication that we gave. So treating DVT these days has become a lot easier, as has many things in the vein world. We can treat it as an outpatient for the most part, and almost everybody. The people who we tend to put into the hospital would be, maybe the elderly, people who are having like a lot of symptoms that we may want to give, other medication to help them be comfortable, but that rarely happens. So, and he'll be on his anticoagulation for about 6 months. And then in addition to that, obviously at some point we're going to do, a full evaluation of his, venous insufficiency otherwise. And we'll be doing something about that. We'll be treating that so that he doesn't continue to have, these episodes of phlebitis.
There is one question that comes to mind on this, and that is, we are such an instant gratification society. We want something fixed. I got a pain. I come into your office. Hi, doc. I heard the radio show. Here's my thing. Yep, you got your thing. Okay, see ya. They don't a pill or shot and everything else. It's not kind of happening, is it? You have to plan out treatment.
Sure.
And there's lots of different ways you can do that. And I'm sure you're going to get to some of that later on.
Yeah.
Where what physical things might be needed besides a blood thinner and a compression stocking. What are we going to have to do surgically to make this guy better?
Right. Yeah. We will definitely be doing the procedural stuff that we do to fix his venous insufficiency in him. And with respect to that, the other thing that was a major concern for us was the fact that here we have a guy who's had a couple of episodes of SVT, superficial phlebitis, superficial thrombosis, in the past. Then he has this episode of DVT after a plane ride. Now his mother had a DVT, so all of that kind of put together is, like I said, putting up red flags. And the question in our mind then was, does this guy, like you alluded to before, was it an event or is it a condition? And, that condition would be is this guy what we call hypercoagulable? Does his blood clot easier than it should?
Okay, on the subject of that, real quickly, if you talk about an event or a condition, can an event create a condition? In other words, if something happens to me, and if I come in and get it diagnosed and treated, knock on wood, it maybe not happen again.
Yeah.
But I'm saying if it's a severe event, even if you fix it, wouldn't I then be prone to get it again? Then it would be a condition, not an event.
Well, yes and no, depending on the circumstance. Okay. But if, for instance, in this guy, what we were concerned about was, did he have some genetic, defect that made his blood clot easier than it should? And we were concerned about that because he's had multiple events.
Right, yeah. Okay.
And his wife or his mother had a DVT. So all of that kind of, points toward a genetic thing. Now he had several events. And if he had one event, then it would be one event. No. Now, I guess, typically, and again, it kind of depends on how you look at it, but, his first event was due to his venous insufficiency, strictly speaking. Now, that although there's a genetic component to that, it's not as concerning, for his long-term health as a genetic, what we call thrombophilia, a genetic predisposition to clot, because if we don't evaluate him further and treat him, he very well may need long-term anticoagulation, which is what we often do for people who we see that have that genetic hypercoagulability. So that's the road that we would go down with that condition, as opposed to let's say he had just one event of superficial phlebitis. We found out that he had venous insufficiency. We fix that, and he's good to go. So we will do what we call a thrombophilia workup. We're going to be checking his blood for hypercoagulation, genetic markers. And as I recall, this guy did have a genetic marker for hypercoagulability, and it then depends on what it is and the specific circumstances, whether we continue to treat him over a long period of time. So that's always that's one of the points that I kind of like to make when we're talking about DVT, especially with respect to DVT Awareness Month. I think there's two things that people need to be aware of, and that is, what situations are they going to be in where DVT is going to be potential, or are they going to be at a risk for developing a DVT? And the thing that we talk about all the time is immobility. This is such a classic story where people are on a long plane ride and they come home and they have a pain in their leg or whatever, and they find out that they have a DVT. That's a very, very common scenario. So there are situations like that where people need to know that really from the aspect of just about anybody, but especially if you're a little older, you have other medical problems, et cetera. You need to be concerned about that if you're on a long plane ride. That's why we encourage people to get up, walk around
the cabin,
remain hydrated, et cetera. And as opposed to, so people have to be aware of that. The other thing that they need to be aware of and keep in mind, and that is that deep venous thrombosis can be a genetic problem. And, if their mother had a DVT and they had a sibling or two that have had DVTs, maybe they had an episode of phlebitis or whatever, maybe they have venous disease, then they have to be concerned that they might have that genetic marker. Now, and especially if you have a parent or a sibling who knows they have a genetic marker for DVT.
Actually, that's a big help, isn't it? I mean, to know these things.
Exactly, and that's part of. That's why I say whenever I talk about March as being the DVT awareness, it's not only the fact that in certain situations I'm at risk for developing a DVT, but it's also being aware of those familial kind of things that might make any one individual need to be a little more concerned about their genetics.
Yeah, and isn't that sort of interesting, because aren't some folks likely to mask that? In other words, it either looks embarrassing to them, so you never see dad without long pants on,
sure,
or mom, and that sometimes they just don't think.
Right.
That it's valuable for family members to know what you're going through, so they can get looked at too.
Sure. Yeah. Right. Exactly. Yeah. So what are the important features about this particular patient? Well, number one, his age. He was 66, and like we touched on before, age is a risk factor for venous disease of any type, and he's definitely into that age range where venous insufficiency and venous complications are starting to increase. And, so you have to be concerned about that, again, especially if you have family history. Secondly, obesity. Obesity also is a risk factor for venous insufficiency and venous disease and DVT for that matter. Again, being aware of these risk factors, you may want to try to alter these things to, kind of optimize your or make your chances as little as possible that this kind of stuff might happen. Smoking is another big thing. And it's just terrible that people smoke anymore, because we know so much about how bad it can be for you, and luckily the smoking as a population we're slowly decreasing, but smoking really impacts venous disease, especially as it pertains to risk for DVT. And especially if it's combined with other things that we'll talk about a little later. But for him, he was obese, very sedentary lifestyle, and smoking, and it all kind of came together.
Great storm, perfect storm, right?
Perfect storm.
And by the way, just as a little reminder, Dr. Randall Juleff is the medical director of Vein Clinics of Hawaii, located on 4 islands. We're talking to you now from the Honolulu office. You can go to veinclinicsofhawaii.com and see a whole bunch of stuff that we're talking about here, including case studies and even some of the actual other shows. And if there's something that you'd like to hear on our Vein Clinic show, you can communicate that way by email. And in the next couple of weeks, we'll be having another one of those mailbag questions where we cover lots and lots of stuff. But today, if you're just joining us, we're talking about something that we talk about a lot, and that's DVTs. You hear about them on TV at night. Here's a 66-year-old guy with what's called deep vein thrombosis as we continue.
Yeah, and in getting back to the website, if people want to send in a little description of either themselves or family member in this way, that we'd be able to discuss.
Isn't it neat the way they do that now?
We would love to have that kind of information to work with. So then the next thing is a recent history of travel, and obviously we talk about that all the time, especially very long plane rides. Is just like I said, such a common scenario for people to travel a long distance. They get off the plane and then they find out that they have leg pain, and if you do, if that has happened to you, then you really need to have it looked into. The other thing about this guy was that he had sudden symptoms in only one leg. If your body is reacting more to increased activity or exercise that you're not used to or whatever, usually it's going to affect both legs or both arms or whatever. And the fact that it's affecting one leg only and not the other, then that's a
big sign.
That's another key thing that you need to be aware of. The next thing with this guy is delayed presentation. So, what I mean by that was that, he was on this plane ride. He started to have pain. he's continued to have some pain after he got off the plane, obviously, but he kind of ignored it for a while.
Didn't you say earlier that he sort of chalked that off to some activities that he was doing
exactly.
while on the trip?
Yeah, exactly.
Sometimes people don't get it; they don't put two and two together. Like
no,
that, right?
no, and I understand it's easy to do, but you have to be aware of this kind of stuff, and so probably what happened was that he gets off the plane and he's still having that nagging kind of pain, but he ignores it. Then 6 days later, the symptoms increase. That's when he started to have much more pain and the swelling. So probably what happened was that the blood clot, when it initially developed, was probably just in the calf, maybe a calf muscle, vein or something. So it was fairly limited when it first started. Had he had immediate evaluation, the extensiveness of the DVT would be nowhere near what it was when it originally developed. So what happened was that probably what it did then do was extend. It got bigger over the course of those 6 days, and then as the clot developed further up into the leg, then that's when he started to have more symptoms, especially with the swelling. The swelling is going to become much more of a problem as the blood clot becomes higher in the leg and into the pelvis. So he could have saved himself probably a little bit of trouble, especially when it comes to long-term secondary problems, which we'll talk about in a second. But if you can catch these things early such that they don't propagate and become very long and large, then you'll be saving yourself, I think, some problems on the back end, definitely. So the next thing is that he had varicose veins. Varicose veins obviously are always an indication of some sort of vein, problem, and we try to educate people all the time. Varicose veins are hardly ever just a cosmetic thing.
But by the way, you did say earlier that this guy he'd had the varicose veins for a long time, and just either they weren't symptomatic to a point where it bothered him, or he just thought, well, Mom had him, Dad had him, I'm okay. I mean, it's just my turn.
Right. And people rationalize it that way too. My family members have it, they didn't do anything, so why should I? But varicose veins always indicate a problem with vein function, need to be looked at. Like we talked about, he had several episodes of phlebitis. That's a warning sign that we've talked about. The mother had venous insufficiency, had vein stripping. She had a DVT, and again, all of that should be a part of any person's awareness. If your parents have a medical problem of any type, because so many medical problems are genetically imposed, but especially as it pertains to vein issues and DVT, if your parents and family members have it, then you have to be concerned that maybe you do too. We talked about the potential for him having a genetic reason to be hypercoagulable, and those the reasons that we are concerned about that was, again, because of his several episodes, because of his mother's vein history, because of his mother's DVT. Be aware of that. People need to be aware of that.
That's where I guess the ultrasound gives you this really dramatic picture. Yep.
Oh, yeah.
All your fears right here. Check this out.
Yeah, it can be pretty dramatic when we look at these things. So, we diagnose DVT with ultrasound, and again, we treat DVT with anticoagulation and compression, and then further evaluation when it's appropriate. But most of the time we can do that as an outpatient, which is a good thing.
The things have to settle down before you can do a procedure. I mean, I do know that some people come in and they've got a big infection. I do know if you go to the dentist and you got a big infection that you're not going to get work done until you take some antibiotics.
Right.
Do you actually have some time where somebody's got to sort of prepare for a procedure?
When people have these acute events, for instance, this guy, well, we're gonna evaluate him.
Yeah.
We're gonna find out if he has some venous functional problems, which I'm sure he does. But are we going to do procedures on him right away? No, we would not. We're going to let that DVT sort of resolve as much as it's going to.
That's with the compression and some meds of kind.
Yeah, right. With the anticoagulation, with the compression, and as much as anything, just time. Because the blood thinners don't dissolve the clot; they just make sure that it doesn't get bigger, and your body really does the work with respect to getting this thing to resolve and breaking the clot down. And sometimes it's surprising how well a blood clot will resolve. Often we see these things, and then a year later, there's really very little evidence.
Yeah.
Now, on the other hand, unfortunately, sometimes we see it, and there are some functional problems because of it. But yeah, that's the way we treat DVT. So are there disease? With respect to the risk of DVT, are there other diseases and health conditions that make DVT more likely? And of course, there are. We always are concerned about cancer patients, as they're going through treatment for the cancer. They are what we call hypercoagulable. Their blood clots more easily than people who are otherwise completely healthy. And so sometimes we run into having to treat, DVT in cancer patients. Pregnancy is, you don't usually think of that as being a clotting problem, but during pregnancy, women are hypercoagulable, and that's why sometimes they can develop DVT, and they can even and they develop venous insufficiency too, or varicose veins that ultimately need to be treated. But pregnancy is another one. Obesity, immobilization, hospitalization. We've talked about this before, where luckily we've had a much higher level of awareness of DVT that occurs in the hospital. Well, why does that occur in the hospital? Because people come in, they have some unrelated problem. Maybe they're being treated for pneumonia or whatever, and the first thing we do is we admit them out to the hospital and we throw them in bed. Yeah, and
immobile. Boom.
Yeah, exactly. They're immediately immobile. They don't feel like getting up. And, they really have to be forced to kind of, walk around stuff. And so probably, 10, 15 years ago, there was a real, luckily, like I said, much higher level of awareness. And, nowadays we have protocols for, prophylactic medications that we give people when they go into the hospital to hopefully, make their likelihood of DVT much, much less. And it works. I mean, it's just making sure that it gets implemented the way it should. Traumatic injury, heart disease, lung disease, smoking, and birth control pills are also things that make the likelihood of DVT, increase your risk of DVT, and especially when you have more than one of them. For instance, women who are on birth control pills, depending on what type of medication it is, some birth control pills are less likely to increase your risk of DVT than others. So you have to, if you're on a birth control pill, you need to ask your physician, is this one that I have to be concerned about? And then also, if you're kind of piling on these risk factors, there's a lot of women out there who are on birth control pills and smoke.
Hey, by the way, I know this might sound like I say, gang, there's no dumb questions. Go to veinclinicsofhawaii.com. Put in a question. I don't care how dumb it is. Somebody's going to answer it, and it's not that dumb. But I'm guessing there's a lot of, particularly men like me, have no idea how a birth control pill works. We just know they take a pill, they don't get pregnant. But, I mean, there must be some real things going on there that pill must stop or eliminate. Otherwise, they wouldn't work.
Yeah.
So is it strong medication?
Well, it is, and it's it's a hormonally based medication that alters the typical cycle of that a woman would otherwise have with respect to ovulation and whatnot. But we have just found that some of those, especially the estrogen based birth control pills, are going to increase your risk for DVT. So you got to be worried about that. Something that we've talked about before is in the medical field we have this thing called Virchow's triad, and Virchow was a physician back in the 19th century, very smart guy. He was a pathologist, but he came up with the what we call a triad of things that make it more likely that somebody might have a DVT. And those three things are stasis, intimal injury, and hypercoagulability. So, again, this kind of goes to piling on risk factors. If you have some reason why your blood may be static, and that's what the stasis refers to, for certain settings, and in certain medical conditions, the blood is not going to move as fluidly as it otherwise should. So if for instance, somebody goes in, has heart problems, gets admitted to the hospital, the blood in the veins is not moving the way it normally would, and if they're for some reason hypercoagulable, then they're going to be at even higher risk of DVT. Yeah. Wow. So the genetic reasons. I mean, we've sort of talked about that. This gentleman probably did or does have a genetic, what we call inherited thrombophilia, which is a genetic reason that his blood clots a little more readily than it should. And probably the most common condition that falls under the category of genetic thrombophilia is something called factor V Leiden. It's a mutation of one of the clotting factors, and we've talked about clotting factors before. Clotting factors are proteins within the blood, and they are some in one state they're inactive, in another they're active, and when they are activated, then the clotting process happens. When factor V is not functioning properly, then you have a higher instance of thrombophilia.
Okay.
And probably that's what this guy had. So, and again, because of his multiple episodes of phlebitis and his mother's DVT, etc. Are there medications that increase the risk of DVT? Yeah, well, we talked about one already, birth control pills. And there are a couple other ones. Birth control pills really are the main thing that we get concerned about as it pertains to a medication that might lead to DVT.
So this was no problem with this guy.
No, he was not on birth control pills.
Yeah, right.
But another medication that can increase your risk of DVT, which is a fairly common medication, is tamoxifen. And tamoxifen is a cancer therapy medication that women take especially after breast cancer. So, and tamoxifen is tamoxifen is a fairly common medication. It can increase your risk of DVT, and again, it's in a setting of somebody who has or had cancer, and just by virtue of the fact that they had cancer, they are hypercoagulable. So again, you kind of have to worry about piling on risk factors, because that's really when a DVT is going to happen. So what are the negative repercussions of DVT? There's something that we refer to as post-phlebitic syndrome, and post-phlebitic syndrome basically results from the adverse effect of that DVT that it has on the function of that deep vein. So
making it smaller, obstructing it a little.
Obstructing it. Number one, but also in the long run, the deep venous system also relies on one-way valves, and when the blood clot forms, as your body is breaking that clot down, you can actually the flow will resume, but often there's kind of a fibrotic residual clot that occurs on the wall of the vein. And that residual clot can interfere with the function of the one-way valves in that vein. So we ultimately, many of these people will develop reflux.
Gotcha.
In the deep vein. Now, what are the repercussions of that? Well, the same thing as insufficiency in the superficial system, except a little worse, because that's going to lead to reversal of flow of blood in that vein. It's going to set up a situation of venous hypertension. And often, when many of the people that we see with real advanced venous insufficiency and skin changes, darkening of the skin breakdown, chronic swelling, all of those things. When the skin becomes real fibrotic, something that we call lipodermatosclerosis, many of those people have deep venous reflux.
Gotcha.
And a good number of those have deep venous reflux because of DVT. So. And that's why I mentioned about our patient that we talked about. There was a little bit of a delay in diagnosis in him. And, when it first started, the blood clot was probably just in the calf. But then over the course of the next 5 or 6 days, then it progressed
working
upward.
its way up there. Yeah.
So if we can avoid that, then we can avoid the negative repercussions of that clot in the thigh vein, which is really, the major segment of vein that's going to, ultimately lead to this post-phlebitic syndrome. So it's important to, again, be aware of your symptoms and to respond to them early rather than delaying. So, post-phlebitic syndrome is something that it's so much more difficult to deal with in the long run, rather than just kind of routine venous insufficiency or getting somebody over a DVT. So what are the things that we can do to protect ourselves from DVT?
From forming up in the first place.
Yeah, right, exactly. So, be aware of your risk. I think, again, when I talk about DVT during, March Awareness Month, everybody should be aware of their risk, not only situational, if they're going to be on a long plane ride, but also, familial, be aware, know about your parents' medical history.
Talk to your doc.
Yes.
Yeah.
If you're on medications that you're not sure about, then some of those medications may be a cause for an increased risk of DVT, especially birth control pills. I mean, there's just so many young women who are on birth control pills. They need to ask their doctor, what kind of birth control pill am I on, and is it the type that I don't have to worry as much about DVT. And then, again, know your situational risks. When you're on a plane, get up and walk around, even though they don't want you to anymore. Stay well hydrated. And, of course, wear compression stockings.
How's our guy doing?
He's doing good. Yeah, he's doing good.
And you know what, gang? You're somewhere you fit into that cycle. And that's the neat thing about Vein Clinics of Hawaii. The quicker you get evaluated to find out what's going on in your system, the more you can get a treatment plan. And that doesn't mean that you walk in there and you're going to be operated on the first day you meet the doctor. That's just not going to happen. But it would bear well for you to take a look at veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. And there's no such thing as a silly question. If you want to get something answered or something addressed, you have a condition, somebody will get right back to you. And the good thing about that is, and we also have our mailbag, and sometime in the next couple of shows, we'll do a bunch of these things, and then you'll find out, hey, there are no dumb questions. As a matter of fact, they're not. That's why we love so much spending this time with you. Tell your friends, come back again and listen some more. It's Vein Clinics of Hawaii. That's veinclinicsofhawaii.com. And one of the other things, by the way, is no matter what happened, what we're doing is trying to multitask here. I'll get right to my phone in a minute. But in the meantime, you have yourself a great day. And remember, it's Vein Clinics of Hawaii. That's veinclinicsofhawaii.com. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.